Hi, my name is Doug Mennin. I'm a professor of clinical psychology at Teachers College, Columbia University. And I would like to first thank the current leadership of SSCP for inviting me to give this virtual clinical lunch talk. And today I'm going to be speaking about an affect science or emotion science framework for treating conditions that are largely characterized by distress, internal distress. And these studies were conducted largely in collaboration with David Fresco, but also with others, other collaborators, graduate students, research assistants. It takes a large team to do work like this that involves both trial research as well as embedded lab and experimental studies. I'll be talking about two sets of studies, those that were conducted at Yale and Temple University a few years back, and more recently a set of studies that were conducted at Hunter College. The ability to become aware of ourselves is a quintessential aspect of being human. To reflect on the past and what went wrong, what we lost, look into the future and try to mitigate those same losses from happening, to get gains that we might not otherwise be able to think about ourselves or see ourselves as if we were a fly on the wall and gain that perspective on ourselves. These are core aspects how we're able to be adaptive in the modern world, but they're also at the source of many types of dysfunction. Our worst misfortunes never happen, and most miseries lie in anticipation, the Balzac said. I have to be honest and say I learned about this quote from watching the TV show Mad Men, but I do think it speaks to its ubiquity as a problem. Gone, glimmering through the dreams of things that were, Lord Byron. Also, our sense of loss and getting caught in loss and not being able to move on. These phenomena are at the heart of types of maladaptive self-referencing that characterize many of our disorders. Worry, repetitive thinking about future threats, often utilized to reduce distress, gain a sense of predictability and control over emotional states. Rumination, as we define it, repetitive thinking about past mistakes or losses, and even self-criticism. You know, think of this like a coach telling you, come on, loser, give me 15 more." This sense that we can criticize ourselves um, to as if we were a third person. And even obsessions, loneliness, yearning, and interoception have been spoken about as forms of maladaptive self-referencing, forms of the ways we utilize our mind to respond to our internal emotional states. And we know that this type of self-referencing has a number of negative associations, negative consequences behaviorally. First off, these type of referencing strategies, such as worry and rumination, often become negatively reinforced by a perceived reduction in negative emotions and a perceived sense of increased control. Individuals, when in uncertain situations or potentially emotionally evocative situations, may turn to this way of thinking and processing information that might give them a sense that they're reducing distress, because they're often not effective in doing that, but they may give enough of a sense of control that they become reinforced, that they become negatively reinforced. They perceive to avert negative consequences. But in truth, the result of these type of strategies, such as worry, is often an avoidance of emotional processing that would otherwise decrease emotional distress, and result instead in increased ability to be conditioned to threat, greater stimulus generalization, and a diminished ability to discriminate stimuli. Rumination itself leads to increases decreases in reward-based learning, and blocks ability to take purposeful action. Even self-criticism is associated with goal hindrance. So although we might call upon it to try to push us and browbeat ourselves into acting stronger, it often results in the opposite effect of making us freeze and feel bad about ourselves and not take instrumental action. Now, this type of self-referencing is at the core of a number of conditions in the DSM. Most obviously, generalized anxiety disorder. This disorder is defined primarily by this type of self-referencing, worry. But even depression Not all forms of depression, but there are depression can be diagnosed through a sense of poor self-worth or inappropriate guilt. Um, so this type of self-referencing is also present in depression. A sort of ruminative depression is common. And these types of conditions have been referred to as distress disorders and have found to sort of coalesce together in structural modeling, particularly by David Watson, Bob Kruger, and others. Um, Colloquially, these conditions are often considered to be, just the worried well or not that impactful. And we know now that that's not the case. That often the distress conditions underlie many other forms of pathology, and can drive the pathology in those conditions as well. These disorders are chronic if not treated and can last a lifetime. They're the most common disorders in older adults. This is unfortunate for those who may struggle with these conditions, but the marital function of these disorders is the lowest of any of the Axis 1 disorders. Um, and they're also often associated with different forms of physical disease and poor health, particularly coronary heart disease, but also functional gastric conditions. Um, and subsequently, these individuals often end up in the physical healthcare system, and cost and increased to a great amount healthcare costs, increased primary care visits, often decrease compensation from work for missed time. So there is a strong impact. And overall, there's also a lowered sense of life satisfaction. People with these conditions often are suffering a lot internally, and people may not see that. But there's often just a poor quality of life reported by these individuals. And when we look at current treatments for these conditions, we find that these distress-related conditions fare poorer than other types of treatments. Here's anxiety treatments from a study by Hoffman and Smits, looking at meta-analytic findings for anxiety using the Cohen's d effect size. We can see that generalized anxiety disorder has only a moderate effect size compared to the other conditions. There's panic disorder here, which at the bottom is sort of strangely not as effective, which typically it is found to be quite efficacious with current treatments. But generalized anxiety being poor is a common finding, and most importantly here, that not that even when people are getting better, they're not getting better to the level of normative functioning. And this is talked about in the G80 field as high end state functioning. How much do people return to get to a place of symptomatic relief and functioning that mirrors people who wouldn't have this condition? And only about 50% get to that point with traditional anxiety treatments, CBT treatments. Um, Also, depression treatments in traditional anxiety GAD treatments, comorbid depression does not fare that well, and people often relapse in MDD into the follow-up periods. In looking at depression findings, this is a Cooper's paper examining CBT versus other types of treatment, and it does overall quite well versus meds as well, but has been found its efficacy in relation to psychoanalysis and supportive therapy is not as strong as one might expect. More importantly, for our purposes, though, rumination itself has been found to be an important determinant of when CBT fails, doesn't do as well. So it seems that when these conditions, worry and rumination, are present, these treatments aren't doing as well, at least in tradition. But we also know that there are a number of new treatments in the behavioral therapy family, that have been getting, particularly for the distress conditions, beginning to improve treatment. And we they there are but however there are a number of components in these approaches, in what are often called third wave approaches, behavioral activation, DBT, ACT, MBCT, and others, as well as adjunctive and alternative treatments like meditative practice and yoga. Um, uh, these have the potential to improve treatments, and we're seeing some improvement. But it's hard to determine what are the processes here that are most essential for treating refractory conditions like the distress disorders. We can ask ourselves what seems to be the most important aspects of these treatments. What should we focus on to improve treatment? Is it exposure to threat? That's a core aspect of cognitive behavioral treatments that should be there, I imagine. But what about behavioral activation? Many of these conditions Many of the individuals with these conditions have comorbid conditions, have both anxiety and depression. So which of these is most important? Is it both? Mindfulness is a large topic and focus in the more recent CBT treatments. Acceptance, cognitive reframing is certainly a core aspect, and should that be continued and included? What about attention shifting and moving, making, creating, applying attention? Values, moving towards things that matter. Um, Flexibility, just generally having more flexible responses, being responsive to the environment in flexible ways. The ability to relax, create quiescence, to detect cues when they come up. General meditative ability, compassion, becoming more compassionate, problem solving, just a general sense of self-efficacy. Maybe that's what's driving all of this. Decentering, or the ability to sort of pull aside your thoughts and see your thoughts in perspective. Diffusion, see the verbal literal meaning of the words in that from perspective. Altering schemas, being interpersonally effective, tolerating distress. How about all of these? These are all processes that we talk about as important in the field and likely have important role to play in treating conditions like the distress disorders. More core or some sort of higher order factor to to these processes that may be important to pay attention to isolate what's most important in treating these refractory conditions. In thinking about trying to develop more mechanism-targeted interventions, there have been a number of initiatives in the field, particularly coming out of the National Institute of Health and Mental Health. Um, as many people are familiar with, the research domain criteria, which is delineating mechanisms and processes that are reflective of examining basic emotional functioning to see where, to disordered functioning, to see where along that continuum processes problems may arise, and to do that at multiple levels of analysis, from cellular, molecular, to neural, to physiological, to behavioral, to subjective, to be able to really get a sense of what might be going awry in normative functioning into disordered functioning. Uh, as well, the experimental therapeutics directive to sort of identify these reliable biobehavioral markers of distinguishing between normative and disordered functioning, and be able to probe these very precise with a focal probe, that a treatment component that will move the individuals with the condition to look more like the normative individuals that are functioning in that circumscribed area. Um, and the idea of personalization, of trying to utilize these targeted therapeutics to tailor them to different presentations that might be based on behavioral or biological indices that help us determine different directions we could proceed in treatment. And allied with this, a few years back, myself, David Fresco, Kristen Ellard, who was one of the authors of the Unified Protocol with Dave Barlow, and James Gross, thought about some of the arguments that were happening in the field in terms of different approaches, more traditional behavioral approaches, more recent acceptance and mindfulness-based approaches. And we're saying, are there sort of commonalities to principle of these CBT approaches that also might map onto our sense of emotion regulation, our basic models of emotion regulation, and RDoC as well. And what we argued was that all the treatments share a common goal of behavioral adaptation, to have the organism be more responsive to its environment in flexible ways, in ways that they could respond most usefully in a given situation according to the demands of that situation and their own internal goals and needs. And that to produce this kind of adaptation, um, we have a number of therapeutic processes we can see on this figure in rectangles that are familiar. These are present in a number of different packages that are used in the field for anxiety and depression, but that these processes reflect overarching change principles that map on to what we know about emotion regulation, based particularly in James Gross's model, and in antecedent strategies that are most effective. So engaging new situations, what we call behavioral engagement or context engagement, um, uh, influencing how we direct our attention or create attention change, and influencing how we think about situations, our own emotions, and our own thoughts, which we can consider cognitive change or even metacognitive change. And these capture, context engagement can capture behavioral exposure and activation, attention change, attention training, and acceptance and tolerance interventions, and cognitive change, classic cognitive reframing, but also decentering and diffusion techniques. And we can see that the black lines, solid lines represent what we think are what we think are the principles that underlie these each of these processes. But of course, we don't have magic bullet processes. And the dotted lines show that when we're trying to influence one, we influence others. If we have exposed people to something they're afraid of, often their thoughts change. If we try to help somebody change their thoughts, often they're more willing to go take new actions. So the question is, can we isolate techniques to be more focally reflective of our change principles? And in fact, there's been great interest in examining more targeted trainings that reflect these, that actually come very principles, and we can see that a number of the computerized trainings that are out there now reflect actually these components of this model: attentional trainings, metacognitive trainings, and even behavioral context engagement training. So attentional trainings such as attention bias modification, where which trains attention away from threat or towards neutral rewarding stimuli; metacognitive training and interpretive bias modification, so modifying cognitive biases through extensive rehearsal of more benign or positive interpretations; and for the behavioral context engagement, an approach-avoidance modification, often with motoric enhancements, and motorically engaging with a joystick, maybe moving towards or retracting from stimuli associated with negative, maybe towards more positive content. So these trainings are meant our approach and improve our ability to be more focal towards these type of principles. However, for the distress disorders, there have actually been weak effects, particularly for worry and long-term outcome in the attention trainings. Although there are decreases in rumination for metacog training, that they were not positively associated with increases in cognitive control. And finally, changes in anxiety and approach behavior were quite small in the behavioral engagement trainings. So although this is a fruitful area of investigation, there may be something about the distress disorders in particular that make targeted training something a little bit more challenging. And to understand that, I think it's important to think about an emotion science or emotion theory framework towards how people respond to emotions in a given moment, the components of that. And an affect science approach argues that emotions are generated to serve behavioral adaptation. So there's sort of a first level response when we're engaged in something emotional, either in the external world or just in our internal environments in our heads. And these are signals for withdrawal towards something something away from something noxious, or approach to something that's important, or both at the same time. But we also often have to course correct. And so we talk about the course correction as sort of a second level or emotion regulation, which is really not another structural area in the brain or a different thing altogether, but rather how our systems then recalibrate themselves to correct that response. So if someone's listening to this talk and they have a thought about something they have to do today, their mind might get drawn away. But and so although that thing might be important, here at this moment, engaging this talk might be important as well to be able to draw attention back. And this kind of regulation involves a coordination of multiple response systems in the brain and body that at sometimes are important to draw together, and sometimes to not call on all systems. And so regulation can happen at multiple levels of elaboration, where involving more less elaborative, cognitively elaborative processes, like just at the attentional level, or more cognitively elaborative processes that involve representation, working memory, semantic processing. And the ability to have flexible responding to different environmental contingencies can be seen as a form of health. And we can, if we think about when this goes awry, we can see that, and this is a model that Dave Fresco and I developed, as a model of emotion dysregulation, a model of the distress disorders, and we can see dysfunction at each of these components. And we can see these components as part of a temporal cascade that occurs in a given moment when someone's emotional, and what might influence that moment. And first, we see on the left that individuals with distress conditions may just have a motivational dysfunction, or you could even view it just as a sense of strong salience. It may not be dysfunctional in itself to have strong responses, but individuals in stress conditions might just have a stronger salience to both or either threat context or reward context. So an individual might be more sensitive to potential threats or potential rewards or both. And that salience, and this is not necessarily pathological in itself, when one may uh, cry at a wedding more, laugh at a movie more, but if they're in an emotional state more, they might need to regulate more. And we see that we argue that those with distress conditions have this initial first response that's stronger, but then also have failure in multiple levels of responding or regulating. And so a secondary response, the second level, might be a failure in attention dysregulation, where less elaborative regulation possibilities are not followed or utilized, where individuals might have, and there's good evidence of this in both anxiety and depression, that these individuals have constrained attention, maybe invariable attention to threat or away from threat, so you don't have more pliance or flexibility attention, and particularly have trouble sustaining attention on something hard or difficult in order to gain important information about how one feels, how one wants to act. Uh, in response to that, they often then also engage as we talked about before, poor maladaptive self-referencing, like worry, rumination, and self-criticism, and fail to engage more healthier uh, healthier elaborative strategies such as reappraisal. And the consequences of these is that individuals often also engage in maladaptive behavioral responses, such as reassurance seeking, physical avoidance, compulsive acts, and just general maladaptive coping. And these type of strategies often then uh, uh, both behavioral and cognitive strategies often then again, as mentioned before, lead to these sort of stereotype responses to the environment, which affect threat learning and reward learning and constrain one's environment. So we look at this, let's look at this in relation to some prototypical individuals, Jane, who's sort of our normative, and we think about intervening on this, on these, what we see are the core mechanisms: attention, cognition or metacognition, and behavioral engagement. We could examine this in two different ways. We could see that we could be maybe potentially more focal by using circumscribed trainings like the modification programs we've discussed, but we could also utilize our therapy packages. However, as you can see in this schematic, that therapy packages bleed into each other. We can't really say some component of the treatment is only attention, affecting attention, unless it's focalized. But it may be important to develop trainings that are focalized, but also to try to hone our current treatments to make them more focalized, to target the mechanisms we think would help improve treatment overall. So we can see this as two different types of approaches. So we can see in this slide that an inductive approach would be to take these trainings and bring them together to capture all the aspects of the ensuing emotional cascade. But we might also look at therapy packages where we hone the components of the therapy package to also be more focal, to be more targeted. So in this way, targeted interventions can both take a deductive approach or an inductive approach. So I'd like to talk a little bit more about the deductive approach of interventions to be more focalized towards a basic model of how emotions cascade and a functional response to emotions. And Dave Fresco and I both view uh, numerous treatments that are being conducted in the field as doing this. That although each of those treatments have their own models of how the treatments are working, we feel it's important to map all of our models onto a common language that not only allows behavioral therapists to speak, but therapists writ large, but also basic psychologists, neuroscientists, and psychiatrists. And the affect science approach is particularly useful for that, and is useful for understanding internal phenomena, how internal phenomena may relate to each other over time. So I'm going to talk in the remainder of the talk. I'm going to be speaking a little bit about approach to treatment that we call emotion regulation therapy, that is trying to do this, is trying to focally target the components, the functional components of an emotion stream and how it might go awry. So in the treatment, we work with individuals to identify their motivational, their responses when they have strong motivational responses, when they utilize self-referencing as a way to cope, and what the consequences are. And that type of self-monitoring and functional analysis is utilized in the treatment. And then in order to increase individuals' ability to gain better clarity and instrumental action in response to those emotional events and during those emotional events, we train individuals in a set of regulation skills that are housed within a mindfulness approach that is specific and specified to a building model of increasing elaborative regulation. So we first teach individuals attention regulation skills that increase pliant attention, more flexible attention, and the ability to sustain attention on things that may be hard. And then we move on to teaching skills that increase more metacognitive abilities, that take more representation, that take more effort, but also allow people to sort of see their thoughts and emotions in perspective and reappraise, particularly around courageous and compassionate, using courageous and compassionate statements, which we see as reframes. And with all of these skills, we utilize formal meditation practices that are focal to each of the skills that we think are important. The ability to orient attention and to sustain attention, ability to center or distance from one's experience and to reframe. So we have a building set of meditations, and then we train individuals on being able to respond on the spot and be able to quickly utilize their skills in a moment. And then and that's in the first phase. In the second phase, to then increase their ability to be proactive, or in other words, to move towards things, contexts or things that may be rewarding, potential, but also potentially risky, and to frame those rewards in those that have intrinsic meaning and value. So that's a quick sketch of what the treatment is about. The treatment's been tested in 8, 16, and 20 session versions. I'm going to be talking a little bit about some of the efficacy research now. Just to say that, again, the structure is basically regulation skills training in the first half and experiential or internal exposure with between session outside external exposure in the phase 2. We tested the treatment largely in 60 minutes with sessions that were 60 minutes in length, but our exposure sessions were often 90 minutes in length. And we have a case conceptualization that the therapist used that maps onto this model. Again, as I mentioned, we ran a number of trials at Yale and Temple University and at Hunter College. I'm going to be first talking about an initial open trial that we ran in a small sample using intent to treat analyses. The sample was largely women and those who were white. And what we show here, we examined the clinician severity rating from the ATIS using, particularly for GAD, the Penn State Worry Questionnaire for worry, the STI for anxiety, Beck Depression Inventory for depression, the Social Disability Scale for functioning, and the Quality of Life Inventory for life quality or satisfaction, FMQ for 5-factor mindfulness questionnaire for different aspects of mindfulness, particularly attending components of mindfulness, decentering and reappraisal. The yellow line represents a large effect size. These are post scores using post effect sizes using Hedge's G, which is more conservative than Cohen's D for small samples. And we can see that we have large effect sizes largely for most variables at post. This continues at 3 months in follow-up and at 9-month follow-up. So we're encouraged by these findings. But of course, we wanted to examine the treatment within a randomized controlled trial, which we did against a waitlist control. This is a minimal attention waitlist control, which means that participants were contacted by phone periodically with limited supportive listening. And the demographics are quite similar. Again, early middle age, and largely women and largely white. And here we have a multi-level model that accounts for missing data. And we see the same indices here. The yellow line is a large effect size. This is, again, now this is between subjects. And we largely show strong effects between subjects in symptoms, quality and functioning, and even in our proposed mechanisms that reflect the model. We see that these gains were actually durable at 3 to 9 months, and we also examined an indirect effects mediation test uh, at pre, mid, post, so 3 time points between those that were treated and those who were on the wait list. And we were able to show that these that our model-related variables were found to mediate outcome in those receiving ERT versus those who were in the MAC where it did not, where mediation did not happen. So this was encouraging. Uh, we, of course, want to examine more conservative indices of outcome. Uh, and so here are some indices of responder status, both, again, using clinical severity rating for the ADIS, but more importantly, examining, as I mentioned before, end state functioning. So do people return to to within one standard deviation of normative response on a number of measures. And so in this case, for GAD, it was 4 out of 6 measures, and for MDD, it was 3 out of 4 measures. And what we see at 9 months is that 80% of the individuals in the trial could be classified as having a high end state functioning in GAD, a strong improvement over past studies using traditional CBT. And in MDD, often not looked at in these trials, but also MDD as well. We have about 63% at 9-month follow-up who are within the normative range as well. More recently, we examined a trial we conducted a trial at Hunter. This was an open trial. Our primary interest was looking at neural and behavioral correlates of outcome. But the trial itself, we examined, again, an IT analysis. We were particularly interested in looking at young adults, so it's between 18 and 29, average age of 23. Again, largely women, but we were interested we conducted this at Hunter, which is a commuter campus, and we were interested in examining a sample which had more ethnic and racial. And you can see on the right is our sample, and on the left is the general Hunter population, which we map onto quite well. Again, the campus is a commuter campus, and given its place on the Upper East Side of Manhattan, many people from the Queensboro or the other boroughs as well attend Hunter, and the demographics here also reflect quite closely the Queensboro. And if we look at this, and again, this young adult sample, what we find, we have many of the same indices. I'm going to just call your attention to the fourth variable here from the left is the rumination scale, the brooding subscale from Susan Hoeksema's measure. And on the far right, we examined measures that were more closely aligned with our model, the affective controls, the attention control scale, the decentering subscale of the experiences questionnaire, and the reappraisal subscale of the emotion regulation questionnaire. And what we find here again is quite large effect sizes using Hedge's G all the way through to 9 months. This was an examination of weekly data in the same study. What we see in red are the outcome variables of worry, anxiety, trait anxiety, and generalized anxiety. And in blue are proposed mediators or models of interest, variables of interest, the EQD, the decentering scale, and the ERQ, the reappraisal scale. And what we see is that we are effectively over the 16 weeks of treatment, reducing worry, trait anxiety, and generalized anxiety, and increasing ability to decenter and reappraise these core aspects of our metacognitive regulation in the treatment. And we found that using a time lag analysis that to test mediation over time mediation, that that the metacognitive indicators were preceded the symptomatic indicators and not the other way around, suggesting potentially that people are learning metacognitive skills before making change on the app. We wanted to examine other indices and along the lines of RDoC, other levels of analysis, examine our proposed model-related variables, our proposed mediators. And so we did this in a number of studies. experimental lab studies. So I talked a little bit about the self-report findings. So I'm going to present some data that looks at some of the behavioral, physiological, and circuit data. And the blue crosses represent studies that we've done that examined indicators along these different levels of analysis in these proposed model-related variables, potential mediators. Just large caveats. The Yale pluses demonstrate a number of different weaknesses methodologically. We have small n's, no normal control maturation, no comparison treatment condition, an inability, given that these are, we have not done dismantling studies to determine whether or not the component that of interest is actually what is moving the targeted component, and maybe something else. We don't have dosing analyses to know how many sessions were needed, particularly for each component, and we don't have enough time points through follow-up to really to effectively determine mediation into the follow-up period. So with all of these large caveats in mind, I want to talk about some of the findings that we have so far. First, that we examined a study in the Yale Temple data set examining heart rate variability, in particular an index of mean of successive difference at an intermediate interval, which is a putative indicator of parasympathetic tone or response. So greater higher scores just mean greater flexibility in responding to emotional events. And what we have here is a video condition which was given at pre, mid, and post treatment. It was in it we examined through the experimental epoch a resting state during the viewing of a fear video. In this case, Silence of the Lambs, which is during a suspenseful anticipatory scene, and then recovery after the video. This is at baseline. For those in red are those before treatment, which is a group of people with GAD who are about to be treated, and at a normative control comparison. And what we see in the normative control comparison is that this video is not particularly upsetting or emotionally evocative to them. So we don't see our typical vagal withdrawal during the fear video and vagal rebound during recovery. Instead, we have sort of a flat, slight increase in fear video response for this. But we can see there's an overall difference across the experimental epoch between those with GAD and the controls, showing that those with GAD have less, have just an overall lower heart variability in flexible response. However, when we look at mid-treatment, this orange line reflects the mid-treatment response of the same individuals at pre. And now we're seeing the more classic vagal withdrawal and rebound response. And we're seeing a quadratic trend here, and a significant effect during the fear video to recovery period. That change from fear to recovery comparatively for mid-treatment compared to pre-treatment, that increasing variability is a strong effect and brings those with GAD closer to what the controls look like, both at baseline, at resting state, and during the recovery period. But a particular change from fear to recovery, from pre to mid-treatment, is associated with changes in pre to post-treatment clinical outcomes in GAD clinical severity, and using a CGI, clinical global improvement index, and in anxiety, the MASC, general distress anxiety, and general distress depression indices, and in rumination brooding subscale, and to some extent in worry itself as well. However, we were not able to determine whether or not people used any of the attention or metacognitive skills we were training, because we didn't have indices during the task of these. So that's an important drawback to this. More recently, in the Hunter study, we examined pre to post resting state functional connectivity of the default network, particularly looking at the posterior cingulate cortex, the PCC, and seeding that, examining its changing relationship from pre to post treatment. And we see an increasing connection with a number of areas, most strongly with the dorsolateral prefrontal cortex, reflecting potentially a greater connection between the default mode network and a task network, an active task network, which might reflect greater cognitive control. The strength of this changing functional connectivity was associated with the improvements, so decreases in depression severity, improved ability to control attention, decenter, and cognitive reappraise. Again, though, we did not actually examine people's ability in these model-related variables of attention, decenter, and cognitive reappraisal. So we also examined task-related data, again in the same trial, the Hunter trial, examining pre to post. And we looked first at a Stroop task to look at conflict monitoring. This is, by the way, in this one, we examined a emotional Stroop task where emotion words were presented over emotional faces, sometimes in congruent forms, such as a fearful word with a fearful face, sometimes with an incongruent, with say a happy word over a fearful face. The reaction time difference between incongruent trials and congruent trials were examined as an index of general conflict monitoring during emotional states, and what we found at pretreatment that was greater activation. These were using whole brain analyses. We found greater insula activation, greater inferior frontal gyri activation, as well as the right middle frontal gyrus, and as well intraparietal sulci and inferior parietal lobe responses. And none of these were active at post-treatment. And this change was significant. This change was significant between pre and post, and particularly on insula, the anterior insula. What we found was that this change and decrease in salience activation from the insula was associated with improving ability to pliantly shift attention, according to the attention control scale. But it wasn't associated with other skills or with clinical outcome. So the ability sort of to pliantly shift attention may be an important factor in amelioration, but may be necessary, but not sufficient. And there's some other data out there by David Creswell, Emily Lindsay, and others that show something very similar, that monitoring or attentional abilities may not be enough to move a number of different indices of outcome. It may take other more elaborative components, such as allowing abilities, saying attention, or more metacognitive abilities to truly move conditions like the distress condition. Okay, in this other task, we examined a classic explicit regulation task, where participants were asked at pre and post treatment to either view neutral IAPS pictures or negative IAPS pictures, and then to either just view them or try to decrease their negative emotions. We did not find either at pre or post treatment differences between look and decrease, but we did find a pooled difference of looking at neutral versus all of look or decrease negative, and improving a decreased negative response to negative trials versus neutral trials at post. And this decreased negative response to negative emotional images was examined in terms of neural correlates. And what we found is that both at pre-treatment, again, this is using whole brain analysis, looking at visual processing areas, we don't see any difference. But when we look at areas that are associated with cognitive control, lateral prefrontal areas, particularly the ventral lateral prefrontal areas, and the dorsal lateral prefrontal cortex, we find that those come online post-treatment, whereas they in viewing negative versus neutral images, and that was not the case at pre-treatment, and that this difference was found to be associated, particularly for the dorsal lateral prefrontal cortex area, was associated with decreasing MDD clinician severity, to some extent, decreasing GAD clinical severity, and indices of the model, including reappraisal, shifting attention, and decentering, but not as much in sustaining attention or focusing attention. Participants are also self-reported improvements in being able to decrease the strength of negative emotion and for it to be less effortful. And they also reported mostly themselves using distancing or decentering and reappraisal techniques are more metacognitive techniques and less attentional at post-treatment compared to who. Finally, we also wanted to examine some of the second half material, the engagement of reward when there's risk, and we examined this at the Yale during the Yale Tample trial using an implicit association task that was developed to examine the positive and negative associations with approach and avoidance. And so, as with typical IAT tests, words are presented and participants are asked to associate those with either with pairings of either congruent pairs, so approach with positive, avoidance with negative, or incongruent, approach is negative and avoidance is positive. General difference between incongruent and congruent trials overall was examined. There's no difference between pre and mid, which is what we would expect, because this engagement aspect really occurs during the second half. And what we find is that indeed we're finding that the reaction time difference between incongruent and congruent goes down between mid and post. And we see this as reflecting a decreased difference between approaching negative stimuli as equal to approaching positive stimuli, so that an individual is maybe more likely to approach all stimuli regardless of their valence. And that change, mid to post, was associated with mid to post change in disability, quality of life, clarity, and dysregulation overall, and also decreases in negative intensity. If you see this is less symptomatic outcomes and maybe more to do with widening sort of life engagement and decreasing negative emotions. Interestingly, the changes in pre to mid clinical did not predict this change. So this change was more predicted by mid-treatment activity. Okay, so just thinking about future directions, obviously, when examining a full treatment package, it's hard to discern where and looking across treatment with not looking at indices during each component, it's hard to determine whether what we said we're doing is actually what was changing them, changing individuals or helping individuals. So dismantling studies are necessary to examine the relative contribution of different components. Also examining issues of sequencing, what's the optimal progression of components, testing whether or not we're actually helping an individual actually learn that component before they move on to another component, and dosing issues, how many sessions does it take to learn a certain component, using potentially smart designs that are mapped onto mechanism rather than outcome. So when is somebody ready? Has they learned what we wanted them to learn before they move on? And other differential trajectories and differential ways to sequence these components based on different characteristics, particularly characters such as neurobiological indices that may be reliable for predicting outcomes. So Connor Liston has some potential neural subtypes that may be important to look at for different potential prediction of different outcomes. And we are also starting to examine computerized versions of ERT that would be either augmenting or optimizing ERT, adding components, computer-based components, or also utilizing more fully computerized components with that have some guided help. We're also revising the approach. We have been revising the approach to address other conditions. We've completed an open trial at Sloan Kettering and a randomized control trial in Denmark, examining caregivers of those with cancer, and we found some good effects that we're publishing. We're also starting to talk about examining veterans without PTSD to see if we can help with resiliency. And we've also in these studies although have not fully analyzed all the data, examining changes in immunological response, inflammatory response, and gastric health, which we know for these conditions are often characterized conditions and may be important to also target. So finally, today I've talked a little bit about an emotion dysregulation model that may provide a helpful heuristic to tying together basic attention and emotion and biological findings with psychosocial intervention. I've argued that distress disorders can be characterized by motivational salience or reactivity, and both early deficits in attentional rigidity and later use of compensatory strategies, and a failure to adapt to utilize more adaptive strategies. I present some promising but very preliminary results for ERT efficacy, particularly possible potential emotion-related mechanisms. But overall, I think it's just mostly important to consider the use of both what I've been calling inductive and deductive approaches to improving treatment. So both utilizing experimental therapeutics to try to build treatments that are more focal, but also taking our highly efficacious therapy package and trying to distill them down to their most essential components and mapping both onto a common nomenclature from affect science of what these components may be. And we look forward to seeing what happens with our work and what's occurring in the field in this regard. Thanks very much. If anyone has any questions, this is my contact information, and I appreciate your time today.